Good morning. I'm Tiffany Reinhardt, and my son has epilepsy. Our first speaker will be Dr. Lorie Hamiwka. Dr. Hamiwka will provide a basic overview of seizures and epilepsy. Dr. Hamiwka is an associate professor of neurology here at Seattle Children's Hospital and the University of Washington. Prior to coming to Seattle Children's Hospital, she was an associate professor of pediatrics at the Ohio State University College of Medicine, Wexner Medical Center Nationwide Children's Hospital. Dr. Hamiwka received her medical degree from the University of Manitoba in Winnipeg, was a pediatric neurology fellow at British Columbia's Children's Hospital, and did a clinical neurophysiology and epilepsy surgery fellowship at Miami Children's Hospital. Her research interests include diagnosis and treatment of the neuropsychiatric and social comorbidities in children with epilepsy. Please welcome Dr. Hamiwka.
Thank you, and good morning, everybody. It's just one of those typical Pacific Northwest mornings, isn't it? Good morning. My goal today is really to kind of review and set the stage for the day and review kind of the basics of epilepsy and just kind of start us from the beginning and walk us through just epilepsy and seizures and give us a foundation for building on the day. And then hopefully at the end, I'm going to get a chance to talk a little bit about some of the comorbidities and some of the things that I'm really interested in, which I could probably talk about for days, but I won't. So I don't have any disclosures, and so my goals today were really to talk about what is epilepsy, what are seizures, trying to bring it down to some very basic terms and a basic understanding, and then what is the chance of having a seizure and developing epilepsy, and then, kind of more importantly, the impact of seizures and epilepsy, because we know that that goes just beyond treating seizures themselves, and we know that sometimes those problems outside of just seizures can be more difficult and more problematic and challenging than the seizures themselves. So epilepsy and seizures can develop in anyone at any age. We know, however, that it's more common in those who are really young and the elderly, and so we sort of see a peak at the young age, and then it sort of drops after adolescence and young adulthood, stays low, and then we get another peak in the elderly. And overall, although there's just a smaller difference between males and females tending toward males, it's pretty much equal. So how common are seizures? So there's probably a 4 to 5% lifetime prevalence of having a seizure. And interestingly enough, when you look at the literature and populations across cultures and across continents, it's pretty consistent among populations. So how common is epilepsy? About 65 million people worldwide are affected, and we have about 3 million people in the United States. And what that means is in the United States, about 1 in every 26 people will develop epilepsy in their lifetime. And we have about 150,000 new cases of epilepsy every year, which is none of this is insignificant, and we don't get the profile probably that the numbers should justify. So what is epilepsy? Well, first of all, it's the 4th most common neurologic disorder, and it affects people of all ages, like we said. Epilepsy really means the same thing as seizure disorder. Those two terms are interchangeable, and we often will get the comment that, well, I don't have epilepsy, I have a seizure disorder. But really, the two terms mean exactly the same thing. They're just a different way of saying the same thing. So epilepsy is characterized by unpredictable seizures and is often associated with other physical and mental problems. And as I alluded to earlier, and will continue to allude to just from my experience, my research, and my practice, these can be much more challenging sometimes than treating the seizures themselves, and can cause lots of problems over the long term. So epilepsy has a very wide range of seizure types. I'm not going to go too much into seizure types today. And then control really varies between people. And so I think when we see families, we always get asked is, you know, is this going to continue? And how do we know if this is going to continue? And what do we do? We're worried, we're scared. And so I think what we can do is give you large number of population numbers, but sometimes because there's so much variability within the disorder, it's difficult. And I often tell people, I wish I could crystal ball, but I can't. And it's time, and it's walking through this together. So we have a medical definition of epilepsy. It looks wordy and complicated, but really we define this as 2 unprovoked seizures that occur greater than 24 hours apart. And what we mean by unprovoked is that there's no underlying cause that we immediately identify. So meaning you don't have a low blood sugar and then have a seizure, or something that we know about that can cause seizures that we can correct. And we want them to occur 24 hours apart, and that kind of goes back a long way from a study that looked at if you had 2 seizures in the same day and we followed those people over time, their outcome was very similar to having just 1 seizure in the day. So we often will define that as just a single event if you've got 2 in the same day. And then we also use it if you have 1 provoked seizure. If you have 1 provoked seizure, and the seizure and the probability of further seizures similar to the general recurrence risk of greater than 60% after 2 unprovoked seizures occurring over the next 10 years. We also you can make the diagnosis of epilepsy if you have a clinical picture as well as an EEG picture that fit into one of our epilepsy syndromes. So what we talk about with those are the childhood absence, juvenile myoclonic epilepsies, the benign, what used to be known as the benign Rolandic epilepsies or the benign occipital epilepsies, which now we call genetic epilepsy. So if you fall into one of those epilepsy syndromes, then sometimes you have 1 seizure, and if it fits, the diagnosis of epilepsy is made at that time. And so epilepsy is considered to be resolved for individuals who had an age-dependent epilepsy syndrome, but are now past the applicable age, or those who remain seizure-free for at least 10 years with no seizure medicines for at least the 5 years. This is it's pretty strict, but we know that if you're 2 years seizure-free, that there's still a significant relapse rate between 2 and 5 years. There's still a relapse rate between 5 and 10 years, but then it falls off so significantly once you get 10 years out that we look at you being very close to the normal population. So that's why that length of time has been determined to be truly cured. So we'll call you in remission, but then the cure is much further out, and we need to see really that time. So I hope that kind of makes sense. I know I took it from the medical definition because I thought it was important to just show that side. So what is a seizure? A seizure is a sudden surge of electrical activity in the brain. A seizure usually affects how a person appears or acts for a short time. So we know there's some sort of change that we see most times. Sometimes the change is only internal. Many different things can occur during a seizure. So whatever the brain and body can do normally, if that part of the brain is affected during the seizure, we can see that as a seizure manifestation. Therefore, that's why seizures are so variable. Sometimes it can just be staring, sometimes it's just a hand moving, and sometimes, it's clearly a seizure to everybody where we've got the generalized seizure. During a seizure, what happens in the brain? So this becomes a little more complex. But when a seizure occurs, generally we think of that as an imbalance between the exciting activity within the brain and the stopping activity of the brain. So we get an over overexcitement. And it's really that balance between the cells that are able to excite brain activity and then inhibit or stop the brain activity. And so brain cells either excite or stop other brain cells from sending information. So it's essentially excitation and inhibition. You need the right balance to kind of contain things. And if that balance is off, well, you get increased activity, which is seizures, but then there are some disorders where you also have too much inhibition, where you don't have enough movement. Some things like Parkinson's disease or those things where you've got too much inhibition. So it really is that balance between the activity. And seizures, again, are a symptom of many underlying causes that can affect the brain. So we can have all the causes from genetic things to, brain tumors. So it's a wide spectrum of, and sometimes we don't know the cause of seizures. And again, seizures just really vary in their appearance. So what can individuals with seizures experience? So we often think of seizures as involving 3 phases. So the first phase is the aura, and I'll go through all of these. And then there's the ictal phase, or what we appreciate as the seizure itself, what's the visual manifestation, and then the post-ictal phase, or that recovery after seizure phase. So the aura is the warning, and we now know that warnings can occur days or hours or days before the event. And so you'll get individuals who will express to you that they just don't feel well, sometimes for days prior to a seizure, and they can kind of tell that something's going to happen. And then sometimes it's just hours. Sometimes it's right before the seizure, and sometimes we're not able to recognize that at all. And sometimes, especially in young children, even if they're having an aura, it may take them some time or some ability to understand what's going on to be able to really determine that there is that warning, and they have that ability to get themselves either to safety if it becomes a big seizure. It's considered part of the seizure, and sometimes it's the only part. So sometimes people will just have an aura and then it stops. And you can have multiple of these per day. And I think we all see patients in the clinic who have had auras for a long time, and then they present with a bigger seizure, and then they'll say, well, I've been doing this for a long time. I just thought everybody had these kind of visions. And weren't really appreciating that that was actually seizure. Teenage boys are kind of common for telling us that, well, doesn't everybody do this? No, everyone doesn't do that. And then there's the mom saying, why didn't you tell me this was going on? So, yeah. So, and then as I said, not everyone has an aura. And so symptoms of an aura can be very vast. So they can be a funny smell. They can be sometimes a sound, so ringing in the ears, a funny sound, a taste, either in the mouth or the back of the throat. You sometimes can have a visual change, visual blurring, strange visual auras, a feeling of panic and fear. Sometimes people will even describe this pleasant kind of feeling, but it doesn't really feel pleasant, but it's kind of pleasant, but it's an unusual kind of pleasant. Racing thoughts. You can be dizzy or lightheaded. Sometimes people will complain of headaches. And then a very common one is that nausea and rising feeling that we see from the stomach to the throat. And then sometimes you can get numbness. The hand will go numb. The leg will go numb, and then you can get progression from there. So then there's the ictal phase, or the seizure phase itself, which is the middle part of the seizure, and that's often what we'll see. You'll see clinical symptoms with that, and that can be anything from just staring or altered consciousness, changes, mouth movements, twitching. or the full body seizure, or any of those clinical manifestations. And then the postictal phase is that recovery period after the seizure. And the recovery can be pretty immediate. So we have seizures in children, especially the absent seizures, where we typically describe as this, immediate onset and immediate offset. So they're kind of there, they're not there, and then they're right back into their conversation. And they literally will, stop, stare, and then pick up their conversation where they left off. And so, those are immediate recovery. And then sometimes it can take minutes, hours, 3-4 hours, and for recovery. And the symptoms of the postictal phase, you can be slow to respond, you can be sleepy, we can see confusion, memory loss, sometimes difficulty speaking, feelings of being lightheaded, scared, anxious, and very rarely you can actually see people go into almost like a psychosis afterwards as well. So again, very variable in terms of the postictal phase as well. So I guess the question we all ask is, does everyone with a seizure develop epilepsy? And that's the biggest worry when people present with their first seizure and present to a first seizure clinic or their primary care. So if there's no underlying cause for a seizure, about a half of people will go on to have further seizures. And we now know that the greatest risk for having a second seizure is within the first 6 months of the first seizure. And then it starts to drop off, and it drops off to about 2 years, and then you get a significant drop off after 2 years. So I always kind of tell families that the first 6 months is the highest risk, and that's when we're most worried, but there's still a risk between 6 months and 2 years, and then after that, it drops off. And I think that after one seizure, I'm not sure it takes a very long time to go right down to the baseline of the normal population, but certainly the risk is significantly decreased. If there's a known cause for seizures, then of course the risk is much greater. So if you've had some sort of injury to the brain, or you have one of the genetic disorders, or something that we know is an increased risk for seizures, then your risk is much higher for having second events. But again, the timing of that, we don't know when the next one's going to occur just because of the unpredictability of seizures. And we know that if we treat you after a first seizure, it really doesn't change. It doesn't change the prognosis, and that's why typically we make the diagnosis of epilepsy after a second event and then discuss treatment usually at that time. Because after you have about 2 seizures, there's an 80% chance or so of having more seizures. So then the risk of having seizures is in a balance with consideration of treatment. So the overall prognosis, so about 30% of people with epilepsy are not controlled because the current treatments available don't work for them. And I always kind of break things down into thirds just because I like to break things down simply. So I'll often say, a third of our group, at least in children, we have good control of seizures, and they're likely to go into remission or long-term remission. And then we kind of have that third in the middle who are controlled on medications and may need to stay on medications to achieve long-term control. And then there's that 30% or the other third who have much more difficulties maintaining seizure control. In only about 6 of every 10 cases of epilepsy do we actually identify a clear underlying cause. So that's just over half, two-thirds, almost two-thirds. So we still don't know the cause in a lot of cases. Doesn't mean we stop looking, but it means that it's just more difficult to find the cause. And about 6 out of 10 people diagnosed with epilepsy become seizure-free. So again, that's kind of what I was talking about, that 2/3, and 1/3 of that is very likely going to go into long-term remission and potentially come off medications, and then there's that third that's controlled to make up the other part of the 60% that need to typically stay on long-term medication. So are there risks for having seizures? Well, most seizures, fortunately, stop on their own. So I think if you look at population data, over about 95% of seizures are going to stop within about 3 minutes. So most seizures are going to stop on their own and then just go straight into the recovery. We do have injuries. There's lots of data on injuries associated with seizures, and those go from very minor injuries such as bruising, cutting. Sometimes people burn themselves, falls, and broken bones, teeth. We lose teeth. But that again is in a smaller proportion of the population where we see even the minor injuries. We do know, and it's gotten a lot of popularity over the last 5 years, the risk of dying associated with epilepsy. So I felt it was important to at least touch on that. And so, we know the overall risk of dying for a person with epilepsy is about 1.6 to 3 times higher than that of the general population. And there's a lot of research right now into sudden unexplained death associated with epilepsy, which, we now know is not completely uncommon. And better understanding of why and who's at greatest risk and how do we counsel are big things that we are sort of involved in from the clinical perspective. And then another drowning. And so whenever we see children in our clinic who present with their new seizures, we talk a lot about water safety and precautions around water, swimming pools, and the bathtub, and just really the importance of not bathing alone and always making sure someone's at home. And, even simple things about, kids falling in the bathtub, and if it's like one of those drains that you just are able to hit and it closes, then you need to pull that right out. Because if you fall and it closes your drain, well, it fills up like a bathtub. So, and, these stories are things that we hear. So just really making sure that we talk a lot about safety, and same with safety around heights and safety around all those things, especially that kids want to do on their bikes and helmets and skiing and helmets and, just a lot of precautions, and just really the importance, I guess, also if they're independent of medical alert bracelets. And so, although most seizures have a good recovery, we need to make sure that we're safe, and we need to make sure that we're just overall safe in case we're in a situation where things may not be as they should. So what if a seizure doesn't stop? So as I said, most seizures are going to stop within 2 or 3 minutes. If they go on beyond 4 or 5 minutes, and we have that history that a seizure has, that someone has had a seizure that is outside of that normal time window, we, again, around the whole safety, need to make sure that we can do something, that they can do something, or their family members can do something to help stop seizures before medical help arrives. And so we would prescribe medications, what we call acute seizure rescue medications, in those cases, because once a seizure begins to go on before 4 or 5 minutes, we know that many of those seizures will not stop on their own. And we know that the most important thing we can do for a seizure that we think may not stop on its own is stop it as soon as possible. Because the longer a seizure goes, often the more difficult it is to stop. And so that's why, schools, for our kids, schools will have the acute rescue meds, and often multiple family members will have them, and, you know, families get very used to, or individuals get very used to carrying these around. And then again, if they're independent, the importance of that medical alert bracelet to tell someone that you've got your medicine in case, you know, it's not EMS is the first person on the scene. So really, again, I think prognosis for status, I think that one of the best predictors is getting a seizure under control quickly and before emergency medical services arrive. So really having that emergency medication with you to stop them. We also worry about seizure clusters. So sometimes it's not necessarily the same seizure that goes on for the prolonged time, but sometimes it's one seizure that stops, but we don't see the recovery period and it goes right into another seizure. And so we classify that almost the same as if the seizure is continuing to go on. We treat those acutely with the Board of Medicines, and usually our definition for a seizure cluster that's treated is 3 or more seizures in an hour. So again, trying to stop that what we call the runaway seizure. I don't know what the right term is, but the seizure that just perpetually continues. So that's another scenario where we would often use a Board of Medicine and worry that things might not be going in the right direction. So we always talk about seizure triggers and trying to avoid seizure triggers. So probably one of the most common seizure triggers is missed medications or delayed medications. So we know that there are individuals out there who can miss medications by only a few hours, and they know that that's already going to put them at risk. So, you know, we always very much talk about the importance of giving medications at times that you're going to remember them on a daily basis. We're all human. I think I always, I don't ask, do you ever miss medications? My question is, how many times a week do you miss medications? Because I think it's a reality. I mean, life is busy, and life is busy if you're not taking medications, and then it's just adding one more thing to the mix. So I always, and you know, we're all fortunate now in this day and age in that we have these PDAs, and we have all these lovely little gadgets to remind ourselves that we need to take our medicines. But I think also, you know, giving families and individuals the opportunity to schedule these at a time that works for their schedule, you know, like consistently at consistent times, so that we do remember to take our medications. And that's also important for us as physicians, because we need to make sure that people are taking medications to know if they're truly efficacious. There's been a number of studies that have looked at what we call adherence to medications, and we know that they're perceived to fail a medication, but it was related more to adherence to the medication than truly failing the medication. So it's difficult. It's a difficult task. It's a difficult thing to get into the routine, and we know that twice a day is usually manageable. Once a day is great, because once a day definitely increases medication compliance. Twice a day is pretty good. When you get to 3 times a day, you're probably down and out. You're going to start missing. It just becomes way more difficult. So we really, again, work to simplify medication regimes as well. Another common trigger, sleep deprivation. That's society now. I think we all feel sleep deprived this morning as we yawn. And so I think it's tough to get enough sleep. But I think that right behind missed medications is just a really common trigger. A tired brain is just more susceptible to have a seizure. So we always talk about really trying to track sleep. And not only for seizure health, I think there's just more and more coming out about just the health around just sleep, you know, related to a lot of other chronic disorders. So I think we always underestimate the value of sleep. Maybe we don't, maybe we just can't get enough sleep. But I always talk a lot about that with my families, and especially the kids who want to go for sleepovers. Like, what do I do? What do I do if I want to go out? Well, you know, the goal is always to normalize life. So, you always say, well, can you have a nap before you go out? Or, you know, how can we, or can you sleep in the next day? Which doesn't always work, because really the brain really likes, you know, the brains that are predisposed to seizures really like that consistency and that routine. So, but we try to talk through some options, and because I think, again, we really want to try to normalize life, but try to normalize it within safety. Anxiety and stress always comes up as a seizure trigger. A lot of times, if that's teased out, again, it's just related to sleep. Stress, when you're going through large periods of stress, you don't tend to sleep as well. And same with periods of anxiety. And so it's always been difficult to tease out the relationship between that variable independently or as it relates to sleep and sleep quality. Alcohol and drugs, again, you know, can lower the seizure threshold from the perspective of just lowering a seizure threshold, but also we always worry about interactions with medications, and then decreasing the efficacy of medications. So again, a lot of these variables loop with one another. You know, we know menstrual cycles in women can be common triggers. We now know that there are biologic mechanisms. I know you're going to talk about that later today, that can be related to that. So we need to think about ways to work through those. There are specific genetic syndromes where bright lights, computers, TVs, flashing lights, you know, even being in the car and having the lights strobe can trigger seizures. And then illness and infection, particularly the fever part, that in many individuals can lower seizure threshold. And then again, you know, how does that loop back to sleep and sleep quality and all of the other things? So I think a lot of these variables are interrelated, but known to be common seizure triggers. And of course, we always discuss these and how are we going to try to alleviate these should they be triggers. So what makes someone more likely to have a seizure? Again, this relates right back to all that other stuff that I've just talked about. But the other point in this slide is that sometimes people have seizures in specific times of the day. So we've got a lot of epilepsy syndromes where they tend to have seizures first thing in the morning or upon falling asleep, which not only are triggers for the epilepsy syndromes, but often triggers for seizures in general, which is often why it's so important that we always ask people to sleep for an EEG or that period of falling asleep into the EEG. So a lot of times, again, when we talk about seizures in the clinic, we talk about, you know, are there any specific patterns that we can target, and why might that be important? Well, medication times, you know. So we always keep a diary. Are there any patterns? Are there any, you know, triggers? Are there any specific times a day? So now I'm going to get a little bit into some of the comorbidities and common difficulties that we see that are associated with epilepsy. So I think in kids and young adults as well, of course, school and learning difficulties are something that we really commonly see associated with epilepsies, and it's across the epilepsies. So we can see it in the genetic syndromes who are well controlled on medications, or we can see it in people who have devastating seizures. So I think it's just, sometimes we think, well, the learning issues are only if you have severe epilepsy, and I think that that's a real misconception, because I think we see children struggling even if their epilepsy seems to be controlled or has a good prognosis. And so when I talk about prognosis with families, we always talk about what's the prognosis for the seizures and what's the prognosis for all the other things that can come with the seizures. So sometimes the prognosis for the seizures can be, yeah, you know, you're going to outgrow this before adulthood, or the likelihood of outgrowing this is really good before adulthood, but then we've still got the learning stuff to address, or some of these other comorbidities to address that may not have the same prognosis as the seizures. So I think that that's a paradigm that's probably shifted over the last 5 to 10 years, where we're not really thinking that it's only about the seizures. We're really starting to look at and focus on all these other issues, because I think at the end of the day, at least for us with young children, the goal is how do we end up to that normal adulthood where we can do all of those things that we all vision for our children when they're 5, for what life's going to be like for them as adults. So, and that's much more than just the seizures themselves. We know that, I can talk a little bit more about that kind of stuff too. And in terms of other things, so we know mood, both anxiety and depression, which I'll touch on, and behavior changes. And then social difficulties are pretty huge. And then, you know, we talked about sleep being a trigger. We know that sleep issues and sleep difficulties, not only sleep duration or the number of hours we sleep a night, but we know that sleep quality can be affected. And that sometimes is related to seizures and the epilepsy, but it also can be related to medications, and we know that there's a lot of other things that can affect sleep. And then we talk a lot about bone health and reproductive risks. I mentioned those, but I think you're going to talk a lot about that later. Next. So comorbidity in epilepsy. So I thought maybe I would just define comorbidity. The term has been thrown around a lot within our epilepsy groups for the last several years. Do we call this a comorbidity? Do we call it coexisting symptoms? Do we say that epilepsy is now a spectrum disorder, like some of the other spectrum disorders out there, where it not only, you know, where we have seizures, but then we have all of these other issues. So is this a spectrum and not only a single entity that involves seizures? And I think the movement has been a lot to call it a spectrum disorder, just so that we get the recognition that this is not only about seizures anymore, it's about a lot of other things. So we say that it's greater than the coincidental association of two conditions in the same individual. Again, mostly behavioral and cognitive difficulties, I think, are the most commonly reported. Although research with some of the comorbidities is pretty limited, and it's ongoing. So we may find that the prevalence or the incidence of some of these other symptoms is much higher than we initially thought. We know that these are more severe if you have intractable epilepsy. Doesn't mean they're not there in the milder forms of seizures and epilepsy, but we know that it's more severe than in intractable cases. And these are all important factors, again, as I alluded to, in just determining the achievement of independence. And as I have alluded to several times, these are really independent of seizure control. So you can have well-controlled seizures, but still have lots of other problems going on. And in some cases, more debilitating than seizures themselves. And, you know, I mean, I ask about these things routinely, and I address them routinely. And so, you know, a lot of times families will say to me, I'm okay, the seizures are okay, but they break down into tears over all the other stuff. Like, why do I have this 17-year-old who just sits at home? You know, and this is not the way I was, when, you know, and this is not what we expect. So I think, you know, just the other issues are just really important, and they're important to families. So I thought I would touch on children just for 1 minute, and then kind of more go to population. But kids do differ from adults, and that's because we're at a time of ongoing maturation, both from the central nervous system and systemically. And I think when we diagnose in children, at least the comorbidities or the difficulties, we have a lot more potential to intervene, and the time to get them to try to resolve the symptoms so that their functional is there. So I think early diagnosis, I think, is the bottom line, and addressing these things very early on in the diagnosis so that you can identify the other problems and continually survey for other problems is really important. And I think if I can just add for a second, a lot of times I just kind of talk a little bit about the research, but we know that sometimes the behavioral symptoms as well as the neuropsychiatric symptoms are there before the epilepsy is. So there have been several studies that have looked at children, and they are mostly from parents' recollection, but have determined that all of these behavioral changes or the mood changes actually were there prior to the seizures. So we know that they're there early on, and when we study them, even in first seizure populations, we know that they're there, and they're there at similar rates than they are in established epilepsy. So it's too much for me to start showing all that data today, but you know, they're there, and so I think addressing them early on is important because we now know that they're there. So in terms of who's at risk, or what are they at risk for, attention and behavioral problems, depression, anxiety, poor social skills, and sleep disturbances are the things I'm going to touch mostly on today. So who's at greatest risk? Younger age of epilepsy onset. We know that there are specific epilepsy syndromes who seem to be at greater risk, particularly for the neurodevelopment or the more severe neurodevelopment. Those tend to be our younger, or what we call the catastrophic epilepsy syndromes. So we do have specific syndromes that we know are at greater risk. And greater risk probably also is dependent on the part of the brain that the seizures are starting from, because we know that there are areas of the brain that are more important for memory and thinking, and then there are areas that are more important for our behavior and our behavioral control and our mood. So if epilepsy is starting in one of those regions or highly involved in one of those regions, there's a greater likelihood that you're going to have those associated comorbidities. If you already have some element of cognitive impairment before epilepsy onset, of course, you're at risk, further risk for deterioration with the onset of epilepsy. And so that goes back to not only defining things when you're first diagnosed, but also following things over time. Because we know that in studies that have followed individuals over time, cognitive function can decline. So sometimes it doesn't, sometimes it does, but it's just important to keep that in mind. And then, you know, as I was alluding to, temporal and frontal lobe epilepsies, just because of the critical function in those areas with regards to memory, behavior, mood, so that those individuals tend to be at greater risk. What do we sort of consider neuropsychiatric and neurobehavioral? The cognitive dysfunction, the behavioral disorders, depression, anxiety, attention, autistic disorders, and sleep disorders. So we consider those kind of neuropsychiatric, neurobehavioral, and then we split those what we call psychosocial comorbidities, which are things like social skills, stigma, we know bullying, and family function. So at the most basic level, they're linked to brain disorders, the brain disorder themselves. And we have some supportive evidence for that, in that there are increased rates in those with more severe disease and low rates in those with other chronic diseases not involving the brain, and that they may be seen at the onset of the epilepsy. Some mild unsupporting evidence is that just because if you go to surgery, we remove the abnormality that's causing the seizures, we don't always remove those other symptoms. And so that tells us that maybe the network is bigger than we initially thought. Brain disorders plus multiple interacting variables, timing of seizure onset and development. We've talked about severity of epilepsy, family function, and family dynamics. So ADHD, we definitely see it in higher prevalence in the general pediatric population, and boys are equal to girls in the epilepsy. They just present differently. But unlike the normal population where we tend to see more boys affected, in epilepsy it's equal. And then more recently, it's also been recognized and reported in adults with epilepsy at about a rate of 20% and about 4% in the normal population, so significantly higher in adults as well, and recently being addressed and studied. Sometimes increased seizure control helps. Seizure medications can sometimes be contributing. And then we always talk about, almost with every comorbidity, we talk about sleep hygiene. And then what do we do in terms of testing? We recommend often neuropsychological testing to make the diagnosis and to just look at overall cognitive function, because we know that that's often an issue at the same time. Anxiety, prevalence is anywhere from 17 to 36%. Worries can be generalized or specific to epilepsy, such as the fear of having seizures, dying during seizures, and the embarrassment of having seizures in public. There are risk factors, so we know that there are people who are higher risk, particularly if you have a family history in our kids, overprotective parenting, if you have learning problems, and sometimes AED side effects and stigma. And then, we have our ways that we can treat anxiety. Depressive symptoms, again, 8 to 23%. So, and then risk factors, again, family history is going to come up as a risk factor for all of these. And so we're started to really ask a lot about that right from the get-go. Cognitive and learning problems are often associated with a lot of the symptoms as well. So again, it's not a single entity. AED side effects, more common in females, adolescents, lower socioeconomic status, and if you don't have good family support environment, and again, stigma and social difficulties. And then, the treatment modalities that we can do with medications and therapies. As well, now we're very carefully always talk about the side effects of AEDs and monitoring AEDs to see if they actually make symptoms worse, and counseling families along that line. I always like to touch on suicide because it's, again, in our groups, our epilepsy groups, we talk about it. We certainly know it's higher in persons with epilepsy, 3.5 to 5.8% higher than the population. And we also know that suicidal ideation is much more common in our epilepsy population. It's a hard thing to ask about. Suicide is hard to ask about. It's just sometimes a really difficult topic to bridge, but I think given a lot of what we're finding, I do think it's important to touch on and at least discuss that this is a risk, and that we often worry about medications and the contribution of medications, but again, family history, other types of comorbidities. Disruptive behavior or behavioral issues, this can be a real issue for us in the pediatric world, just as it pertains to functioning in school and in other environments. But again, the prevalence really varies depending on the studies that you look at. And then again, lots of relationship to all of those other studies, all those other variables. I wanted to touch a little bit on psychotic disorders because those can be seen as part of epilepsy, as part of seizures themselves or the psychosis associated with seizures, but also we see more psychosis in people with epilepsy. And then just quickly, because of kids, the autism spectrum disorder and the relationship between autism and epilepsy and reverse. We know that there's a higher incidence of epilepsy in individuals with autism spectrum disorder, but the reverse is also true. So epilepsy puts you at a higher risk for autism spectrum. And we know that there are certain epilepsy syndromes or certain groups of kids that we need to look for this in. And I think early screening really does affect the prognosis. So again, screening for these issues. We know that people with epilepsy are also at risk for other chronic diseases, so 2 to 5-fold prevalence of other chronic diseases. Now again, whether this relates to sleep, whether it relates to just The other comorbidities and overall health, don't know what the relationship is, but we do see higher rates of diabetes and all of the other chronic disorders in people with epilepsy. That's been documented in a few different populations. And then, again, just the psychosocial stuff, which was just a big scope for me to talk about in this talk, but just always to keep in mind that we know that people with epilepsy are less likely to have a close network of friends. They're more likely to be living alone. They're less likely to be married and have families. So just really thinking about the whole social impact and the stigma impact, I think is just really important. So we know that epilepsy and seizures can develop in anyone at any age. Demographically, they're relatively consistent among populations. We know about a third do not respond to medical therapy, and that it's associated with a number of comorbidities. And that's the end of my talk. Thank you very much for your attention.